Now the next topic is the mucopyramid carcinoma. Now we are coming to the malignant salivary gland tumors. Right? Now it is the most common malignant salivary gland tumor. In case of benign, it was polymorphic adenoma. In case of malignancy, it is mucopyramid carcinoma. It is the second most frequent of all the salivary gland neoplasm in occurrence. The term was first coined by Stewart Becker in the year 1945. It consists of 5% of all the salivary gland neoplasms. Now, the etiology which is implicated in mucopyramid carcinoma is the therapeutic radiation, the radiation which is used for treatment of diseases. Then we have lipoidal installation or any other presence of foreign material within the gland. Now, the origin is the cells of the salivary gland, excretory as well as intercalated ducts. Now, coming to the clinical features, mucopyramid carcinoma is mostly seen in the, or it is most common in 3rd to 5th decade of life. More in females than in males. Side parotid gland is the most common gland which is affected, and intraorally it is the palate. And it is the most common salivary gland neoplasm which is seen in children. Coming to the clinical presentation. First, we have the low-grade variant, which is slowly enlarging, painless mass, seldom exceeds 5 centimeters in diameter. It is not completely encapsulated, often contains cyst which is filled with viscoid as well as liquid material. Sometimes the people, or rather, the mucopyramid carcinomas mistaken as mucosal. Then we have the high-grade variant, which grows rapidly. Since it is a malignancy, it will also bring facial nerve paralysis, ulceration. Then you have trismus, draining from the ear, you have dysphagia. It has metastasis to regional lymph nodes, lungs, bone, brain, and subcutaneous tissues. You can see in this photograph the blue pigmented mass on the posterior lateral side of the heart palate. And in the lower photo, you can see the mucopyramid carcinoma on the tongue. It is also linked to some genetics also. Infrequent genetic loss at chromosomes 9q21, 8q, 5p, 16q, and 12p. HRAS genes have been shown to have mutation at codon 12 or 13. This is the genetic part. The tissue which after biopsy, what we receive, you can see in the photograph First is the low-grade micropyramid carcinoma, which may have a distinctly cystic cross appearance. You can see the cystic spaces filled with viscoid and mucoid material, and few areas of hemorrhage are also seen. The cut surface shows gray-white solid mass, which is accompanied by multiple small cystic structures and infiltrative borders. Now coming to the histopathological features, it is usually characterized by variety of cell types and growth patterns. Now, four types of cells are usually commonly seen, or the tumor is composed of four types of cells. First is mucosecreting cells, then we have intermediate cells, epidermoid cells, and then we have the clear cells or the columnar cells. Epidermoid carcinoma, it is of three grades are using: low grade, intermediate grade, and high grade. The mucoses, they vary in shape, have pale foamy cytoplasm, which stains positive for mucin stains, as it is filled with mucins. Relatively large, may assume round, cuboidal, ovoid, and columnar or goblet shapes, stains positive for mucicarbon and fast stain. Epidermoid cells, they are squamous and have polygonal shape. Intermediate cells, they are larger than basal cells, smaller than squamous cells, and the progenitor of epidermoid and squamous cells. They are considered to be progenitor cells. Then clear cells, they are large, polygonal, with a defined cytoplasmic borders. The histopathology grades are usually given on the basis of the amount of cyst formation, the degree of cytoplasmic atypia, and the relative number of mucous, epidermoid, and intermediate cells. Low grade. Now coming to the low grade variant, the hallmark feature is the prominent cystic structures, which is accompanied by the presence of numerous mature cellular elements, including mucous cells and extracellular matrix. In this variant, the mucous cells they are usually predominant. Squamous cells lining the cyst spaces are also seen. The size, shape, and staining characteristics of all the cells are uniform. Intermediate grade. Intermediate cells they predominate with scattered mucous cells and zones of epidermoid cells forming large solid islands of tumor. Mitotic figures are rarely seen. You can see in this photograph, this is the low grade variant with a prominent cystic complex. So you can see the various cystic spaces. The intermediate variant with few mucous cells and common population of intermediate and epidermoid cells. High grade variant. It shows us proliferation of epidermoid and intermediate cells, mostly epidermoid cells. Degree of age, quite a noticeable amount of cellular ATP is seen. Nucleus to cytoplasmic tissues also altered, with prominent nuclei and mitotic figures are numerous. Two differentiation patterns are also seen in mucopyramid carcinoma. First is which resembles the variants are sclerosing mucopyramid carcinoma is extremely rare shows central sclerosis that occupies the typical tumor. They infiltrate of plasma cells, eosinophils, and other lymphocytes at its periphery. Then we have two mechanisms are involved. First is the tumor infarction, and second is the extravasation of the lesions, which is resulting in the reactive fibrosis. Then intraosseous mucopurulent carcinoma. This primary intraosseous mucopurulent carcinoma of the jaw bone, it is extremely rare malignant salivary gland tumor, comprising only 2 to 3% of all the mucopurulent carcinomas. It's more commonly seen in the posterior part of the mandible. Histologically, it is a low-grade cancer. Radiographically, it is seen as unilocular or multilocular lesion. Photograph which is attached, you can see the posterior part of the mandible is affected. The differential diagnosis is necrotizing silometaplasia, then we have pleomorphic adenomas, then we have inverted ductal papilloma, then we have cyst adenoma, then we have metastatic squamous cell carcinoma, then we have sebaceous carcinoma, clear cell tumors, and adenosquamous carcinoma. Treatment is, and the prognosis part. Excision is the or typical conservative excision with the preservation of the facial nerve. If submandibular gland is affected, the removal of the gland is preferred. Any minor salivary gland is affected, surgical removal. Metastasis is seen in 12% of the cases. Prognosis is fairly good. Then we have next topic is actinic cell adenocarcinoma. It is a salivary gland tumor malignancy which shows serous acinar differentiation. Abrams and his co-workers have concluded that the tumor of this type have at least low-grade malignant potential. It is defined by a cytological differentiation towards serous acinar cells, whose characteristic features of cytoplasmic false positive Zamolan type secreting immune cells. It constitutes around 17% of all the primary salivary gland malignancies and 6% of all the salivary gland neoplasms. Histogenic theories was given by Warsol and later by Regis and Vatsakis, which says that this tumor arises from the stem of the reserve epithelial cells, which are located at the tubuloacinar terminal of the salivary gland duct, or that is the intergalactic duct bridge. Clinical features: the tumor is mostly seen in middle-aged persons, approximately 44-45 years of age. Females are more affected than males. The ratio is 3:2. The site is parotid glands are affected more, approximately 80%. Intraorally, leaves and buccal mucosa, they are more involved. Regarding the clinical presentations, it is a slow growing, mobile or fixed mass of variable duration. Asymptomatic, usually pain and tenderness seen over a third of a patient. Facial muscle weakness can be seen. Bilateral synchronous tumors have also been reported. As you can see, the actinic cell adenocarcinoma seen as a small or nodular mass on the heart plate. The histopathologic feature is highly variable morphologic features, which is well circumscribed and encapsulated. May exhibit infiltrative growth patterns. The characteristic cell is the serous cyanide cell with abundant granular basophilic cytoplasm with round and darkly stained eccentric nucleus. Mitotic figures are shown. Now the morphological growth patterns is seen in the solid, microcystic, papillary cystic, and follicular. The individual cells, they are seen as acinar cells, intercalated cell, vacuolated cell, clear cell, and non-specific glandular cell. Solid growth pattern is most easily recognizable, contains large number of very well differentiated acinar cells, and most closely resemble the normal carotid gland. It is composed of sheets of tumor cells that frequently have an organelle configuration. It is a group of tumor acinar cells which are separated and surrounded by a very thin fibrous septa that contain small, nearly invisible capillaries. The clear cells, they are often macrocystic pattern. It is extensive in 1/3 of all the cases. Numerous small cystic spaces are seen. Acinar cells still frequent, may be a dominant dominating type. Vacuolated intercalated cells are prominent, and mucinous material may fall in the cystic spaces. Then we have papillary cystic pattern, in which the cystic structures that contain the proliferation of epithelium, which is projecting into the ligament. Some epithelial projections have fibrovascular pores, whereas the others appear to be masses of epithelium without apparent supporting stone. Epithelial proliferations, they may vary in thickness. Intercalated and non-specific glandular cells, they predominate, and vacuolated cells are also seen. The apical portion of the lumen lining cells, they bulge into the lumen, which is producing a kind of hobnail-like configuration. Then we have follicular pattern, which is the less frequent type. It is of variable size, over to round cystic spaces, which is lined by tubercle to low columnar epithelial cells. Cystic space, they contain a proteinaceous material that may stimulate the appearance of a colloid. Intercystic areas, they are usually occupied by epithelial cells that are non-specific glandular cells with some vacuolated and acinar type of cells. In this photograph, you can very well see the acinic cell carcinoma with extensive semoma body formation. Acinic cell carcinoma showing focal clear cell change. In the upper photograph and lower photograph, you can see the typical acinic cell carcinoma, which in areas of high-grade carcinoma, small cell features. This phenomenon has been referred to as dedifferentiation. The differential diagnosis includes the normal salivary gland, hydatitis, microepidermal carcinoma, microcystic type, papillary cyst adenocarcinoma, and clear cell oncocytoma. The treatment and prognosis part. Surgical excision is the treatment of choice, with the preservation of facial nerve. Then we have lymph node dissection. Internal tumors, they are surgically excised, and prognosis is poor. The next topic is adenoid cystic carcinoma. Now, the adenoid cystic carcinoma, it is more common and best recognized salivary gland malignancies. It is slow growing but is aggressive neoplasm with a remarkable capacity of recurrence. The perineural invasion is considered to be the hallmark of advanced cystic carcinoma. Now, the advanced cystic carcinoma, it is a basilar tumor consisting of epithelial and myoepithelial cells in variable morphologic configurations, including tubular, cribriform, cystic, and solid patterns. Clinical features more common in the 5th to 7th decade of life, more in females than in males. 50 to 60% of the cases they occur in minor salivary glands and more commonly seen on palate than on tongue and buccal. Clinical presentation, it is a slow growing mass. Pain is a common finding and it's the important one. Patients they usually complain of constant low grade dull ache with gradually increasing intensity. Facial nerve paralysis may develop within the parotid tumors. Parietal tumors can be smooth surfaced or ulcerated. Tumors arising in the palate or maxillary sinus may show radiographic evidence of the bone distress. Adenoid cystic carcinoma, which is the painful mass of hard palate and maxillary alveolar ridge. Whole of the alveolar ridges you can see in this photograph. On excision, the adenoid cystic carcinoma of the parotid gland has well delineated parotids, as you can see. And in the lower photograph, you can see white or grayish white color is form and the invasive kind of tumor, and areas of hemorrhage can be also seen. Coming to histological features, the adenoid cystic carcinoma is composed of a mixture of myoepithelial cells and ductal cells that can have a varied element. Three major patterns are usually seen. First is the cribriform pattern, then you have tubular pattern, and then you have solid pattern. Usually, a combination of all these three is seen, and the tumor is classified on the predominant pattern. Cribriform pattern is the most classic and best sequenced appearance, which is characterized by islands of basilar epithelial cells that contain multiple cylindrical cyst-like spaces, which is resembling a Swiss cheese or a honeycomb. These spaces often contain a mildly basically mucoid material and a hyalinized eosinophilic product, or a combined mucoid hyalinized appearance. Sometimes the hyalinized material also surrounds these cribriform islets. The tubular pattern, as you can see, the tubular structure which is lined by a stratified choroidal epithelium or longitudinal section ductal structures are also visible. The lumina usually contains fast positive material, and cribriform pattern it may also exist with the tubular pattern. Both the patterns can be seen in a same tumor. The solid pattern is a solid group of choroidal cells with a little tendency towards the duct or the cyst formation, arranged in nests or sheets of varying size and shape. Areas of necrosis is seen. Cellular pleomorphism and mitosis is also observed. As you can see in this photograph, solid variant showing scattered duct-like structures within the tumor. Next, you can see the upper photograph showing the tumor cells are surrounded by hyalinized material. And the lower photograph, you can see the tumor cells invading now that is called as the perinatal invasion. Differential diagnosis is basal cell adenoma, PLG, polymorphous low-grade adenocarcinoma, basal or squamous carcinoma, and basal cell adenocarcinoma. Coming to the treatment and prognosis part, surgical excision is a treatment of choice. The adjunct radiation therapy, which may greatly improve the patient's survival in some cases, and prognosis is unfortunately poor. Now coming to next salivary gland malignancy, is called as polymorphous low-grade adenocarcinoma. It is also called as globular carcinoma. It is also called as terminal duct carcinoma. It is the recently recognized type of salivary malignancy. It was first described in the year 1983. The term was first used by Evans and Matsakis. This malignancy occurs exclusively in the minor salivary glands. It is characterized by bland, uniform nuclear feature, diverse characteristic architecture, infiltrative and perinatal condition. Clinical features is more common in older age group, that is 50 to 80 years of age, more common in females, 2:1 ratio seen. Like 50 to 60% occurs on the palate, 16% is seen on the buccal mucosa, 12% is seen on upper lip, and the parrot, if occurs, if at all major salivary gland is affected, is the parrot, which is more commonly affected. Clinical presentation most often appears as a painless mass that may have been seen as a present for a long time and with a slow growth. This will be associated with bleeding, discomfort, injectasia, and ulceration. The tumor can erode or infiltrate the underlying bone. As you can see this photograph, ulcerated mass of the posterior lateral side of the heart. Coming to the gross pathology. It is firm, circumscribed, but non-encapsulated. Yellow tan lobulated nodule average is 2.0. Bony invasion may be seen in large regions in the heart palate, may impinge upon the medullary bone and can cause bone resorption as well as the literally medullary invasion. Now coming to the histopathological features, this characterized by infiltrative growth with diverse morphology and uniform nuclear appearance. At lower power, the tumor sometimes appears to be well circumscribed. Peripheral cells are usually infiltrating, invading the adjacent tissue in a single file fashion. It shows the different growth patterns, therefore, hence the name polymorphous is given. Variety of growth patterns, solid, ductal, cystic, tubular, or cribriform patterns. The tumor stroma, it varies from lucid to hyaline, and some is separated by a fibrovascular stroma. In some tumors, a cribriform pattern can be produced that mimics adenocarcinoma. Mitotic figures are uncommon, perinatal invasion is common. It's photographs. The upper photographs usually shows a medium power view, a cribriform arrangement of uniform tumor cells with pale staining nuclei. And the lower photograph you can see pale staining cells which infiltrate in a single file box. Next slide is again photos. The upper photo shows the tubular structures which are predominantly lined by single layer of small body cells, and the lower photograph showing the multiple pseudocystic spaces with pale staining amphiphilic mucoid content resulting in a cribriform appearance. The differential diagnosis is pleomorphic adenoma and adenomocystic carcinoma. Coming to the treatment part, the polymorphic low-grade adenocarcinoma is best treated by wide surgical excision, sometimes including or resecting the underlying bone. Metastasis to regional lymph nodes is relatively uncommon, occurring in just under 10% of the patients. Therefore, radical neck excision seems to be rather unwanted. And distant metastasis is also rare. Today we will be discussing disturbance in size of the teeth or the tooth. In this part, first we will discuss the macrodontia. What is the term used when one or more teeth are smaller than microdontia may be generalized. It can also be localized. Generalized, it is called as true generalized when all the teeth are uniformly smaller than the other. Causes pituitary dwarfism and Down syndrome. Then more terms there that is called as relative generalized. When the comparison is done, when the mandible or the maxilla, they are somewhat larger than the teeth, but they are larger, but the teeth they are of normal size. So in this, the teeth they are of normal size, but as the mandible or maxilla they are somewhat larger, therefore gives the appearance of macrodontia. That is called as relative generalized. Then we have localized when only one tooth is involved. And in this case, the maxillateral incisors are the most commonly teeth which are affected. As you can see in this photograph, the maxillateral incisor is affected, or is smaller than the other teeth. And the second photograph, in this photograph you can see, since it is a macrodontia, the teeth are small. You can see the spacing in between the teeth. Now, the next topic is macrodontia, when one or more teeth are larger than the normal. Same goes with macrodontia, is generalized and is also regional. Replaced. Generalized is fully generalized when all the teeth are uniformly larger, and relatively generalized when the mandible or the maxilla is somewhat smaller in size, but the teeth are of normal size. Then we have regional, that is seen in fetal hypertrophy one side, and segmental odontomaxillary dysplasia. Rhizomegaly, when only the roots are larger than the normal. Here you can see in this photograph, maxillary central incisor is somewhat larger than the other. Disturbance in the number. First, it is anomalia. It is the term used for the congenital absence of quality, and is also associated with hereditary epidermal dysplasia. Then we have another term which is called as hypodentia. The congenital absence of one or more teeth third molars, nucleated incisors, they are the most commonly teeth or the most common action teeth. As you can see in the first photograph, you can see the lower arch, the front anterior teeth, frontal and lateral incisors they are missing. As you can see in the OPG also, that the teeth are missing. Then we have the disturbance in the number of teeth. First is the supernumerarity. This is the term used when the teeth are in excess of the normal number. 90% of the cases are seen in maxilla. Examples of supernumerarity include in maxilla it is mesodense, paramolar, and lateral incisors. In case of mandible, it is premolars, paramolars, and multiple supernumerary they are seen. They are more common in Gardner syndrome as well as in pseudocranial dysplasia. As you can see in this photograph, there is a mesodense you can clearly see, and in this second photograph you can see an extra premolar, mandibular premolar. Then you have this disturbance in the eruption. First is the premature eruption, which includes the little teeth and unital teeth. The little teeth are when erupted, or the teeth which are present at the time of birth. The unital teeth, that the deciduous teeth which erupt during the first 30 days of life, are called as unital teeth. When premature eruption is seen of entire common dentition, it should be, you can suspect the possibility of hyperparathyroidism. You see the little teeth in the mandibular arch, on the mandibular arch. Disturbances in eruption, delayed eruption, eruption later than the normal age of eruption is usually idiopathic, rapid, and it is also associated with certain systemic conditions such as rickets, pseudocranial dysplasia, and catechism. Ginger and also gingival fibromatosis. The practically, the teeth is an eruption that is impeded by a physical barrier. What are the causes? The causes include the dental crowding, then we have supernumerarity coming in their pathway, and odontogenic cysts and odontogenic tumors, mostly odontomas. Most common are mandibular and maxillary premolars, which are followed by maxillary cuspids. Now the impacted teeth, they are classified according to their orientation. First, they are classified as mesoangular, then you have distal-angular, then you have horizontal, then you have vertical. According to the stage of eruption, when they are completely impacted, when they are lie within the bone, and partially impacted when they lie partly in the surface. Impacted teeth. Then we have partially impacted teeth that communicate with the oral cavity are more prone to peripheral. Complications include the root resorption of the adjacent normal tooth, infection, pain, few of the Impacted third motors, they show the development of dentigerous cyst and the action is often on the impacted person. As you can see in this photograph, you can see of OPG showing the horizontal impact, horizontal impacted tooth in the mandibular. The disturbance in the eruption is called as lateral sequestration. Is a small spicule of calcium tissue that is excluded through the alveolar mucosa that overlays the alveoli. Disturbance in the shape, the dilation is a sharp band or the angulation involving the root of the tooth. Causes trauma during the tooth formation, continued root formation during the third or the tortuous part of the eruption. These are the most common causes of implication. Then we have parodontism. It's the condition when the molar with an elongated crown and a tightly placed percussion of the roots are seen, resulting in an enlarged rectangular curvature. It occurs because of late invasion of earthquakes. Disturbances in the shape. Then we have first dens invaginatus. It is a developmental anomaly. It is characterized by deep enamel line that extends for varying depth into the underlying acne, which places in the pulp chamber apical. Then we have supernumerary curves. The teeth containing an additional curves. Examples include the Talens curves and the cusp of parabola. In this photograph, you can see the cusp of parabola in the maxillary first molar. Then we have dens invaginatus. It is usually characterized by cusp-like supernary enamel protrusion on occlusion on the or on the lingual surface of the jaw. Photograph is showing the premolar with an enamel protrusion. The next condition is gemination. Single root tooth with unusual wide and partly divided crown or two separate crowns. Then the next is fusion. It is a term used when abnormally shaped tooth are seen with wide crown or a normal crown with an additional roots. The main cause is it results from the union of two tooth germs. Then we have concrescence. It is union of roots of the two or more normal teeth by their cementing. Causes include the trauma or the interceptive bone loss. Then we have hypercementosis. When one or more teeth with excessive deposition of cementum of roots. Causes are include increase or decrease of occlusive forces, previous disease, hyperpituitarism, and chronic infection. Then we have cervical enamel predictions. It is the apical extension of the coronal enamel beyond the smooth cervical muscle. Because you can see in this photograph, here is the cervical enamel condition. In this photograph, you can see a hemispheric structure which may consist entirely of enamel or may contain the underlying dendritic. It is mostly present in the roots of maxillary or mandibular nerves. Then we have disturbances in the structure of the enamel. First are the acquired factors, which include the environmental factors, the bacterial and viral infection, and the inflammation, nutritional deficiencies, chemical injuries, and trauma. Genetic part includes androgenesis imperfecta. And we have focal enamel hyperplasia. When the enamel hyperplasia is seen in one or two teeth. Examples include sternal tooth, results from the localized inflammation or trauma during the tooth process. The enamel has fitting areas or deformed with yellowish or brownish. The next enamel hyperplasia, the systemic or environmental factors inhibit the functioning of the glass. Enamel has horizontal lines or small bits or grooves. Example, Jensen's incisors and mulberry molars due to congenital surface, unit line, and fluorosis. It is usually seen in hypocalcemia, that is, vitamin D deficiency, lesions, chickenpox, scarlet fever, vitamin A and C deficiency. And you can see in both the photographs, the generalized enamel hyperplasia. That means all of the teeth are affected. And we have fluorosis, also called as fluoride mottling. First is the minimal fluorosis, when only the smooth enamel surface with white flecks are seen. It is mild fluorosis when the smooth enamel surface with white opaque areas and moderate to severe splitting and brownish discoloration. This is called as severe when enamel is softer and even in a normal resulting in excessive. These are largely resistant to ACEs. And you can see in this photograph. You can see the more white flecks on the tooth. Brownish discoloration is also seen. And on the second photograph, you can see some fitting areas are also there. Then the next topic is androgenesis imperfecta. It is a heterogeneous group of genetic disorders exhibiting faulty enamel formation, affecting both the primary and secondary. Now, generally the normal enamel formation is seen in three phases. First is the enamel vertex formation, then we have the mineralization part, then we have the maturation of the enamel. Accordingly, three types of emergency imperfecta are identified. First is the hyperplastic type, is focal or generalized. Is the increased enamel formation by disturbance in the function of angioblasts, The enamel is thinner than the normal, and the radio density is greater than that of the dentin. Now we have hypocalcified enamel, which is defect in the mineralization of enamel. Enamel is of normal thickness, but is usually softer than it can be easily removed with a blood instrument, and radio density is lesser than that of the dentin. Then we have hypocalcified type. This when the defect is in the mineralization. And the enamel is usually of normal thickness, but is usually softer than the normal. It can be easily removed with a blood instrument. And radio density is lesser than that of the dentin. Third is the hypermaturation type. The focal or generalized weakness of nature enamel crystallite. The enamel is of normal thickness, but is less harder in the centuries. Very synonymous no example is no captain. Hypermaturation in focal or general areas of immature enamel crystallites. Enamel is of normal thickness, but is less harder in the centuries. Examples no captain. Then we have Witkoff and soft classification. First is the hypoplastic type, fitted autosomal dominant, local autosomal dominant, smooth autosomal dominant, autosomal dominant, autosomal recessive, and smooth flexible. Then we have hypoplastic type, autosomal dominant and autosomal recessive. Hypermaturation, autosomal dominant, flexible recessive, invented autosomal recessive, and smooth. You can see the generalized pattern. That is the condition affecting all of the disturbance in the supplementary. That is the terminating video under dysplasia. Genetic pattern to the deficiency of factor type 1, type 2, and type 3. Then we get dysplasia type 1 and type 2. Then we have familial hypophosphatemia. That is the vitamin D resistant. The next topic is deficiency of imperfecta. The hereditary defect, which is consisting of population teeth composed of irregularly formed unmineralized dentin that obliterates the pulp chambers in the plants. Types, we have type 1, which is associated with imperfecta. It is also characterized into sclera. Type 2, heredity of the dentin is the most common type. Type 3 also comes as a radial type. It is also same as type 1 and type 2. Show the multiple pulp exposures of testosterone. These features, both the dentitions are affected. Population teeth with usually to brownish or yellowish discoloration, still there are seen. Development of dentin enamel can be easily checked off. Despite the exposure dentin, these are also prone to fail. Histopathology. The mental dentin is normal, whereas the remaining dentin is severely dysplastic. amorphous matrix with globular and interglobular areas of mineralization, and irregularly widely spaced disoriented entities. And you can see the generalized entities. Radiographically, type 1 and type 2 bulk shift counts are seen, prostrate cement mineralization, some roots are seen, and varying degrees of occlusion of bulk chamber and canal cirrhosis. Type 3, same features forming extremely large bulk chambers, which is surrounded by thin shell of dentin. Then we have dentin dysplasia, the hydrated effect, dentin formation. The root dentin is abnormal and roots are short and tapered. They are also called as rootless teeth. Then shows autosomal dominant pattern. 2 times type 1 affecting the roots and type 2 sperm affecting the top. Types, the radical dentin dysplasia. This only reduced chances of mechanism, more common than type 2. All teeth in both the dentitions are affected. The teeth often show increased mobility and they explode prematurely on their own. Histopathologically, enamel and ventral dentin is normal. The remaining coronal and root dentin consists of nodular masses. It is composed of tubular dentin and osteoid. Slit-like for remnants may be seen between the mountain muscles, which gives an appearance of lava flowing around them, which is considered to be a hallmark of rootless tooth. And you can see the in this photograph, it gives the appearance of lava flowing around molars. Coming to the radiographic features, you can see the photograph, the roots are flat, short. They also may be apparent and diagonal. Mandibular roots, they have trapezial roots, and in addition, they show the augmentation of pulp, chambers, and canals. And the patient shaped member to the pulp may also be seen. Dentin dysplasia type 2, that is the permanent type. Both the dentitions are affected. Flexuous teeth with bluish clay, brownish or yellowish discoloration. Same translucent or fluorescent appearance as seen in dentinous imperfect. Common teeth, they have normal clinical appearance. Histopathologically, the deciduous teeth, they have normal zone of mental dentin that changes abruptly into dense amorphous dentin with irregular arrangement of tubules. Prominent teeth, globular and interglobular areas of dentin, pulpal sort of dentin with tubular, atubular or tubular dentin. It has pulp stones in the pulp chambers and narrow pulpals. Radiographic features which shows the deciduous teeth showing the augmentation of pulp chambers and canals as seen in dentin dysplasia type 1 and type 2. Roots are normal. The pulp chambers and the common teeth have become masked. The facility for the plain cleft pulp chamber can be seen. Pulpy peripheral calcifications are also seen in the coronal cleft. Reason to dysplasia is also called as the ghost teeth. In this, the defective formation of the enamel and dentin is seen. with abnormal pulp and follicle calcifications, with surrounding soft tissue hyperplasia, along with the accumulating spherical calcifications and chondrogenesis. The next topic is regional auditory dysplasia, is also called as ghosty or ghost tooth. In this, there is a defective formation of enamel dentin with abnormal pulp and follicle calcifications, with the surrounding soft tissue hyperplasia, along with the accumulation of small spherical calcifications and chondrogenesis. Clinical feature, it is more common in maxilla. It affects several entities in the same quadrant, mostly seen in common dentition. The deformed teeth with soft ledgy surface and discolored or yellow brown color. Histopathologically, you can see the dysplastic or the interglow dentine, and widening pre-dentine layer, and an enlarged volume with food stones. Photographic features, as you can see, the X-ray. The ghost teeth is usually showing the decreased radio density. The enamel retina very thin and large curved chambers. Okay, curved stones are also. So, you can see in this photograph, the showing like the teeth with ghost-like appearance in the left quadrant and the right prominent central side. The next topic is difference disturbances in the structure of cerebellum. First, hypophosphatasia is disorder of bone mineralization, which is caused by deficiency in alkaline phosphatase in serum and in tissues. With autosomal recessive and autosomal dominant, there is delayed formation of and development of dentition. There is premature loss of primary teeth and spontaneous loss of permanent. Radiographically shows the enlarged pulp chambers and pulpings. Histopathologically, the absence of non-reduction in the thickness of cement. OPG, you will see very little amount of cementum is can be seen. Enlarged pulp chambers and enlarged pulp canals can also be seen. Now, coming on to the soft tissue abnormalities. First, we have congenital lip pits. These are congenital involutions on the lower lip. It results from the persistence of lateral calci on the embryonic mandibular arch. It involves the pyramidal portion of the ganglion of the lower or upper lip. It is autosomal dominant condition. It may be associated with Salivary or black parrot. It may be unilateral or bilateral. We have crucial lip pits. These are small nuclear incisions at the corners of the mouth. Autosomal dominant condition. More common in males, approximately 1 to 4 mm deep. Results from the failure of fusion of embryonic or thin mandibular processes. They develop later in the life and they also express like anomaly. This is an anomaly which is characterized by horizontal pole of mucosal tissue that is usually located in the inner aspect of the upper lip. It is usually congenital acquired autosomal dominant condition. It may be associated with Usher syndrome, which is characterized by double lip, developmental glasses, non-toxic thyroid. As you can see in this photograph, showing the thickening on the inner aspect of the lip, and the second one showing the developmental plexus and function of the eyelids. Then we have frenulum tag. It is a rendered piece of mucosal tissue that projects from the macula labial. Autosomal dominant finish may be mistaken for purpose of aphasia, and study shows normal mucosa. Next condition is called as microglossia. Common developmental condition of unknown cause. Tongue is smaller than the normal. Entire tongue may be present at aglossia. Mostly occurs in association with oromandibular activity. In calabrosia, commonly known as tongue tie, developmental anomaly is the lack of normal tongue mobility because of the abnormal fibrous tissue attachment between its ventral surface and the floor of the mouth. This is 4 times more common in birds. It shows high mucosal wall attachment of frenulum resulting in the parental problem. And the condition macroglossia of the large tongue. So this when coordinately is mostly seen in Down syndrome, with Whiteman syndrome, Men syndrome, hypoplasia, cretinism, and neurofibromatosis. Secondary, it may be result from it results from lymphangioma, hemangioma, myxedema, amyloidosis, acromegaly, cretinism, angioedema, carcinoma, and other tumors. Macroglossia of the last time, it is most caused by vascular malformations and usually also muscle hypertrophy. It is usually manifested by noisy breathing, drooling saliva, difficulty in eating, creating little water, and fungi. It is also associated with Whiteman syndrome. Now, the back with Whiteman syndrome is usually characterized by omphalocele, and viscerally, gigantism, immunity, hypoglycemia, and increased circulatory circulation. Then condition, the next condition is called rhesus glandus. There are multiple small endogenous macular structures. These are collection of topics of sebaceous glands identified. One common is the buccal mucosa and on the lip. 80% of the population generally have these products glands. More common in adults than children, puberty is considered to is implicated in their development. This photograph you can see for an image was on the buccal mucosa. Histopathologically, you can see the focal connections of sebaceous glands are there. Then next is white sponginess. It is an autosomal dominant hereditary condition. In this, the oral mucosa is white, thickened, and folded. It may be present at the birth, possibly appear at the early childhood or adolescence. Its causes include the mutation in creatine K4 and K13. Clinical features include asymptomatic whitish, in color. May appear translation similar to nuclear tumor. May be widespread involving the buccal mucosa, tongue, gingiva, palate, and throat. So that the histopathology you can see parakeratosis, is seen, then the intracellular edema of the small cell. Now the disturbances which involving the bone. First is hemifacial hypertrophy. That is the half side of the face is affected. Causes include the increased neurovascular supply to the affected face, and there is increased prevalence of abdominal tumor, especially the root tumor of the kidneys, along with hemifacial hypertrophy. Clinical features include more common seen in females, more on the right side. The affected side is enlarged, soft tissues, enlarged, teeth are enlarged, frontal bone, maxilla, palate, mandible, and process all are enlarged. The skin of the affected side is thick and it is coarse. Trichosis is also seen, and there is inverted alignment of the circular niche face, which may result in retardation and the seizures. Clinical features include the premature development and eruption of teeth, which may be enlarged in size, unilateral macroglossia and malabsorption. Differential diagnosis include neurofibromatosis and fibrous dysplasia. Disturbances involving the bone. Now, in this, the next topic is hemifacial hypertrophy. It is also called as Rosenberg syndrome. It is a degenerative condition which is characterized by trophic changes affecting the inside of the face. Causes are peripheral nerve dysfunction, trauma. Clinical features. It is usually onset is during the first decades. The atrophy of skin and the subcutaneous structures on the affected side. Bones, they also may be affected. May also be affected. Then we have female predilection. The skin may show dark pigmentations. The sharp line of demarcation, which is obvious, is having a linear scar between an open and abnormal skin. It's called a strike-off spot. Anophthalmos, falling of the cheek and orbit. Then we have tangent neuralgia. The patient may also suffer from myelinosis. The clinical features, as you can see in this photograph, the mouth and the nose are located on the affected side. Unilateral posterior open white is seen and in a direction. Syndromes. Papillon-Lefebvre syndrome. It is an autosomal recessive condition. There is severe destruction of the frontal structures affecting the family as well as the permanent entity. Hyperkeratosis of the palms of hands and soles of the feet. Etiology include the immunological disorder due to the impaired activity of T and B cells. There is chemotactic effect. There is reduced ability to eliminate Staphylococcus aureus and Candida albicans from the oral cavity. Features include there is normal development and erection of teeth, which is followed by palmar and plantar keratosis with gingival swelling and bleeding. Frontal pocket formation precedes the loss of restless teeth by the age of 4 years. Gingiva becomes normal until the erection of the teeth. Structural frontal disease reappears and communities are lost by the age of around 14 years. As you can see in this photograph showing multiple IFUs, the bone loss is quite evident in all of the X-rays. Down screen, the typical number of chromosomes in a human cell is 46. Out of 46, 22 pairs of autosomes are there. It's 44 in number. In one pair of 6 chromosomes, that is X and Y. One set of 23 chromosomes is inherited from the biological mother, and the other set is inherited from the biological father. When an individual is missing a chromosome from a pair, it is called as monosomal sample syndrome. When an individual has more than 2 chromosomes of a pair, it is called as trisomy. So when this trisomy occurs in the 21st chromosome, the individual has 3 chromosomes in the pair 21st rather than 2, resulting from Down syndrome. Clinical features include the person suffering from Down syndrome may have their eyes that slant upwards, small ears that will fold over at the top, small mouth, making the tongue appear large, small nose with a flattened nose, nasal bridge. Some babies may have short neck, small hands, and short fingers. Adults are often short with unusually limber limbs. Now, children with Down syndrome, they can do most of the things as any other young child can do, such as walking, talking, dressing, and training for the fully develop. But these things they develop usually later than in the life than in the other children. Down syndrome will result in some degree of mental retardation also. The degree of which varies widely. However, many will learn to read and write also. Many people with Down syndrome, they are also employed and they frequently live semi-independent. Heart defects are seen in 30 to 50% of the cases. Intestinal malformations occurring surgery occur in 10 to 20% of the cases. Visual and hearing impairments occur in 50% of the cases. Occur in more than 50% of the cases. Then there are thyroid problems, adult onset leukemia, epilepsy, diabetes, and Alzheimer's occurs with more frequently. The higher rate of infections due to compromised immune system and decreasing the number of infections. Oral health problems include the dry mouth caused by mouth breathing and is usually associated with upper respiratory infections. Periodontal disease that's related by increased number of infections. Then we have chronic dry mouth, that is stone and fishing of the tongue and lips. We have the ulcers, oral feedback infections, and acute necrotizing ulcerative gingivitis also. Orofacial features include underdevelopment of or hyperplasia of mid-facial region, a smaller range of nose, horns of the midface and maxilla, is open white or glass, female occlusion, tongue may protrude and appear too large. The sides of the heart palate are abnormally thick, but it gives the appearance that the palate is narrow with a high wall. Occasionally, parietal cleft-like folds are also found. There is reduced degree of muscle tone in lips and cheeks. Small nasal vessels contribute to mouth breathing. Less space in the oral cavity for tongue, affecting speech, mastication, and natural cleansing of teeth. force of tongue greater than the force of teeth closing grasp malformation. Some dental problems are also encountered. Microdontia is seen in 35 to 55% of the cases. Hyperplasia and hypercalcifications are also common. Congenitally missing teeth occur in 50% of the cases. There is delay in the eruption of dentition. As you can see in this photograph, the clinical features of the oral findings which include broad lips, open mouth with protruded tongue, macroglossia, fissured tongue, fissured lips, and narrow palate, malabsorption. There's delayed eruption of primary and terminal teeth, parodontitis, methodism, uveitis, and the rest of it. Now, very frequently asked question for Down syndrome is there any cure? No, there is no cure, but it can be prevented. As the scientists, they do know why the problems occur, why the problems are involving the chromosome 21 occur. One more very frequently asked question regarding Down syndrome is who has been an increased risk of having a baby with Down syndrome? The parent who already had one child with Down syndrome and the mother over 35 years of age. So you can also do triple screening, detection of alpha beta protein and unconjugated estriol and human chorionic gonadotropin in the second trimester, which helps in screening the Down's syndrome during the anomaly time. Trisomy 21 is present in 94% of the cases with Down syndrome. Mosaicism is a condition where there is a mixture of normal deferred and trisomy 21 cells occurring in 2%. Now, the mosaicism is a condition in which the cells within the same person are different. The remaining 3% have a Robertsonian translocation in which all or the part of an extra chromosome 21 is fused with. You can see in this photo the boy is suffering from Down syndrome. Now, the persons with Down syndrome usually have mild to moderate mental retardation. School-age children with Down syndrome often have difficulty with language communication. And adults with Down syndrome have high prevalence of Alzheimer's disease. Now, who are at risk of having a child with Down syndrome? It is mostly seen in when one case in out of 1,300 persons for a 25-year-old woman. At an age of around 35, the risk increases to 1 in case 65, and at 45, the risk of having a child with Down syndrome increases to 1 in every 30 years.